Colleen Yacoub. I'm Deputy Vice Chancellor here at the University of Reading. I'd like to extend a very warm welcome to you all to this public lecture, Designed for Life, Building Cities That Make Us Healthier. Now, these lectures were relaunched last year after a short break, and it's been wonderful to see such interest in hearing from our academics about research that really makes a difference. For more than 45 years, this series has shared ideas that connect the university with our wider community, and tonight's topic does exactly that. Now, my own background is in nutrition, so I'm really used to talking about how lifestyle and genetics affects our risk of chronic disease. But what about our surroundings? The way our cities are built, the spaces we move through every day, they might have a bigger effect on our health than we realise. And we're very lucky to have two fantastic speakers to help us unpack that idea tonight. So first of all, Professor Kathy Payne, who holds the Henley Business School Chair in Real Estate Development here at Reading. Professor Payne is an international authority on sustainable urban development, a fellow of the Academy of Social Sciences and several professional bodies, and an advisor to governments around the world. Her recent work looks at how the property and planning sectors can build health outcomes into investment decisions, an idea that's changing how we think about development. And joining her tonight is Professor Antoni Chan, Clinical Lead in Rheumatology at the Royal Berks NHS Foundation Trust, as well as holding a joint professorship here at the University of Reading. He's a Fellow of the Royal College of Physicians and a member of the British Society for Immunology. Professor Chan brings an invaluable clinical perspective, helping us to understand how the design of our cities translates into real impacts on people's health. So without further ado, please join me in welcoming Professor Kathy Payne and Professor Antoni Chan.
I think Antoni is starting, yes?
Yes, yeah. Okay. All right, thanks very much.
Come on,
Thanks very much. I've been waiting 20 years to give you this lecture tonight. And the reason is because I want to start with an observation that I see in my clinic every day, the patients that I meet every day. And this observation has turned into this question. And the question that I'd like to pose to you tonight is the postcode that you live in just as important as your genetic code? Now, when you think of healthcare, the first thing that you probably think of are hospitals, medicines, injections. How is it that we can think of healthcare differently in terms of the environment we live in, the streets we walk, the air we breathe, the parks we walk, the things we eat, the people we interact with? Isn't that also part of the whole healthcare spectrum? And just like to consider that tonight in tonight's lecture. As humans, we have evolved with buildings. It's not something new. Although I'm talking to you about something that I've been thinking about the last 20 years. Someone called Vitruvius, in the Roman architectural architect, had written this 2,000 years ago. And the way we have evolved is that we used to live in caves. These were shelters to protect us against harm. And then you can see over time, the whole aspect of health has been very much embedded and integrated into buildings. When you go traveling, you might see riads, you might see pools, you might see things where water, fresh air, plants, gardens are somewhat integrated into buildings where people live. And the whole idea is that health and building are not two separate things. In fact, this idea has been going on for a very long time in the buildings that we see. Here in the Royal Berkshire Hospital, and I work in the hospital is not only a place of sanctuary, but also a place of sustenance where people come, and the idea is that they will get better in that time. And we have, from COVID, we have learned that not only is it important to talk about drugs, but also about the well-being of people. And so as a result of COVID, we have now the Oasis Center where staff can go in their busy day to spend time and appreciate the surroundings and re-energize themselves. And we also have a garden in the middle of the hospital, the Anglefield Gardens. And in fact, this is where the very place that we would see people during the pandemic spending time here with their family and loved ones. People who come out of intensive care would walk in these places. So this whole idea that buildings and the environment are very much intertwined is an idea that I'd like to propose further tonight. And so we have two things. We have genes, and all of us know about genes and what they can do to you. It probably results in how you look and how tall you are. But we know about genes. We can't change that, not yet at least. But also we have the environment. And the environment and the genes interact with one another to result in the diseases that we have today. So think of the gene as the script and think of the environment as the director. And we know there are many different types of directors. The same script can be played out in different ways. In the same way, the same gene, people with the same genes can somewhat express disease differently, depending on the environment, depending on the situation, and depending on the lifestyle. And that's the environment. And you can see here a list of conditions that can result from this G and E combination. So we know about the genes, and the part of the genes that which are made out of DNA that codes for a certain protein, we call that a gene. Now that cannot really be changed. Of course, there are new technologies with gene editing coming up. But also there's something called epigenetics. I'd like to talk to you about what epigenetics is. On your genes, there are things that can happen to it. If you like, these are the on and off switches that can switch off a particular gene or make a gene replicate and make more of that protein. And these epigenetic phenomena are very much affected by the environment. So there are processes like methylation, histone, microRNAs. These things are happening to our genes without changing the code. So it's an on and off switch for us. And the important thing I want to share with you tonight, that a lot of these epigenetic changes are reversible. So although you can't change your genes, there are things that you can do to change the epigenetics and the switches on your gene. And if you have a lot of changes on the gene, then you can start measuring this. And this is where we come to the idea of biological age versus chronological age. So if we have two people who are 50 years of age, one person can actually be 40 years of age biologically, and another person could be 65 years of age in the biological age. It depends on what have you been doing, whether you smoked and you didn't really look after yourself. And you can measure this by the amount of epigenetic changes on your gene. And if you have more of these changes, what happens is that you're more likely to increase your risk of disease. And the disease that we're talking about is the non-infectious disease, not caused by a virus or bacteria, but non-communicable diseases, heart disease, cancer, stroke, diabetes. These things increase your risk because you've used them up too quickly, and you've not preserved them. And so we can measure this. And this has shown that more changes in this has resulted in more disease that we see today. So what can we do about this, and how does this interact with our environment? So these are the three things that we want to talk about. We know about your genetics. That's what has been coded for you. We also talk about epigenetics, but the big thing that I think we don't often talk about is the environment. When we talk about healthcare, we want to try to modify the gene or the epigenetics, but what about the environment? And there are a lot of things around us. The built environment, the buildings that we live in, where we spend most 90% of our lives indoors, the neighborhoods that we live in, have a huge impact on our epigenetics and how we express these genes, which eventually lead to disease. The other thing that the environment can affect is your gut bacteria, or we call them microbiomes. There are trillions of these bacteria around. And if you look at studies where people have migrated from one part of the world to the other part of the world, there are bacteria changes. And there are signatures of these bacteria that can affect how we express disease and affect the epigenetics again of how we express disease. In other words, your microbes or your bacteria know where you're going to. Your bacteria know where you're traveling to. This is better than your iPhone. They know where you're going and how you're changing and how you're expressing yourself. And so we can see this in population studies. And these are another factor that can change the epigenetics and how we express disease. And the single most important one are these non-communicable diseases. And so I call these the infamous five. They're not famous. These are things we don't want to have, yes? You've heard about cardiovascular disease, number one, heart attack, strokes, cancer, chronic respiratory disease. This will be a winter. We'll see a lot of this, COPD, asthma. Diabetes increasing all the time. We are now seeing more and more of this, younger people getting it. And on this side are the diseases that I look after. So rheumatoid arthritis would be one, osteoporosis would be another one. There are all these other ones here. The thing is, this, on a global scale, if you were planning a healthcare in a hospital, this is 7 out of 10 of deaths are caused by these conditions. In the UK, we're doing better than that. You'll be pleased to know. 8 out of 10. In the latest report, we're going to reach 9 out of 10 of deaths are from these things. Yet we wonder how we can modify these by drugs in hospitals. There's no doubt that's important, but what about the environment where people live for 20, 30, 40, 50 years? And what are we doing about this when we start planning buildings and environment that we live in? So here is a nice chart that I show you. It starts with the environment you're in, what you do about it, the travel that you do, the way you live, whether there are parks around you, and then that changes your behavior. If you have a place where you can walk to, a place where you can breathe fresh air, and a place where you feel connected, that to me is a healthy city. If you don't have any of those things, you don't feel connected, you don't feel safe, you don't feel there's any place to walk to, and the air is probably not very fresh, then one has to think about whether that's a healthy place to live. That changes the behavior, and that results in the biological response that we see, the epigenetics. And these things are happening all the time. They're gradual. It won't be a sudden thing. And then results in disease. And this is why we often see these diseases in general later in life. Yes, we get older, we often see a lot of these, including dementia, depression, cancer, diabetes. And here's the chart that I want to show you, that NCDs, non-communicable diseases, are on the rise. Whereas communicable diseases have come down, we have a lot of very good treatment for HIV, for a lot of infectious disease. We saw a little bit a blip during COVID, but that's got better now. We have better vaccines as well. And injuries obviously will always be that depending on people's lifestyle. But the NCDs are what we are talking about. And can we roll it back to the beginning? When we think about our buildings and environment, rather than the end, which is coming to hospital, and we're spending a lot of money to look after this, could we go upstream is the question. Can we do a bit better than waiting for it to come downstream where it's costlier to treat someone? And in my own specialty, in rheumatology, if I can just take one example, is that this is rising. We are seeing more and more people, younger people, getting back pain, knee pain, hip pain. And if you look at this, at the age of 45, you should be relatively healthy and doing lots of things. Already 10% of people in the latest report in Reading have either hip or back pain or knee pain. And that's going up, and 1 in 3 of people will have this. And what is really interesting is that this is even higher in the area of deprivation. Now, you might argue, is it just because of economic reasons? But I think it's more than that. The deprivation is not just due to economic deprivation, but also infrastructure deprivation. The inability to go out, the housing, the places that they live in, could certainly affect some of these conditions that we see. And so in arthritis, in rheumatoid arthritis, for example, the epigenetic clock is quicker. If you look at this, the chronological age and the biological age is different. The biological age is far greater than the chronological age. And this leads to autoimmune diseases that we see. And by the time they come and present, this has already happened over the many years before that. Here's a map of Reading. You could think of where you live. You can see these are the areas of deprivation. Now, I think the message here is not just economic deprivation. It's about infrastructure as well. If you go into these places, what are the facilities available in these places? And how do we promote healthy living in all of these wards and areas? And in some of parts of Reading, these are the most deprived nationally as well. So while we may have some wealthy suburbs, there are also areas of very high deprivation. So there are 4 things that we must think about when we talk about the building and environment. These are the air, the temperature, the noise and stress, and the green space and safety. The air that we breathe is quite important. If you're indoors, the air can be more polluted 2 to 5 times if there is no good ventilation. So that's important to think about. If there are people smoking in the building, there's passive smoking. These are triggers for a lot of respiratory diseases, cardiovascular diseases, and even arthritis. On the outside is the traffic pollution, where you live and how that impacts your health. So really, if someone's going to stay in a house for 20, 30 years, I like to say that housing is actually a frontline health intervention, way before people develop these diseases. And the treatment is not more and more medicine. The treatment is to see how we can change some of these environments that people live in. Secondly, the temperature. This is right in the middle, where we are aiming for an 18 to 21 degree. That's where humans thrive, in the room temperature. If it's too cold, you have respiratory illnesses. If it's too hot, you can get cardiovascular and immune system problems. You can't get it both ways. You need to stay in the middle, right? So that's where a healthy design, where this is taken into account, can actually help improve health. Number 3, noise and stress. We don't like this. This is getting too noisy. And this activates a lot of our stress pathways. This is how we are developed. When we hear a sound, our stress hormones go up. And if you keep hearing that every day, you're in a stressful state. You probably don't sleep very well. You become quite depressed. You become quite angry, irritable. And that's not really good for your immune system and all your things that's happening around your epigenetics. And so building buildings, when you're planning, is to consider why you're building it near something that's very noisy, a factory or somewhere industrial. And this stress can really accelerate your biological age. The 4th is green space. So if you can have a park, you can have a plant, and you can have a pathway, and you can have a pavement, that improves your health. So if you can think about these things where people can walk home, they can, it releases the stress, it's safe to walk, and also it's safe, there's no crime, then people will engage in this. And this is another really important way of trying to improve health. Certainly for arthritis, movement is good. So my motto for our patients is motion is lotion. If you keep moving, you lubricate your joints, you probably get less cardiovascular disease, you probably control your weight, and you probably feel healthier and happier as well. So design matters. If we can design this into future developments and retrofit some of the current old Victorian buildings that we have into this type of approach, I think then that we probably can flatten that NCD curve that we are seeing. So I think there are huge opportunities for healthy living, and I call this healthy by design. The place that you are makes the health. And the postcode is just as important as your genetic code. And I showed you that there are studies now, not just studies of association, but studies of causation, that these things are really important. The interplay between the gene and environment is quite important in terms of how we see disease being expressed. And so we need to target these areas, the deprived areas, not just economically, but also structurally and infrastructure-wise, and embed air quality, safety, and green space into our planning. And this is when clinicians like myself and the university, Professor Payne and the team can come together. And one of the things that we have been doing is to develop something called the Health Innovation Partnership, or HIP. And this is a collaboration between the hospital and the university from 2021, and being anchor institutions where we need to kind of promote this health message. We need to try to influence some of the planning that goes into these things in order for us to have a future in the NHS that is not going to be so swamped by these things, the non-communicable disease. And here is a good example of how this can work locally in Reading, so that we can, if you like, make that Berkshire pound, that £1 go as far as possible in the future. And with that, I'm going to pass over the the lecture to Professor Payne, who's going to talk to you further about the research that she has been doing on this topic.
Well, thank you, Antoni, for that brilliant start to the lecture. And I just want to say, with reference to the HIP Health Innovation Partnership, that I just feel this is a role model which needs to be developed, not just here at this university and in this area, but at other universities around the country, and to involve other partners as well, local authorities, communities like you this evening. So thank you very much for that. So now I'm going to go on a slightly different tangent to talking about the research that I've been in charge of here at Reading. Turning myself on. So as has been said already, I'm a Professor of Real Estate Development in the Department of Real Estate and Planning in the Business School here at Reading. And the work that I've been doing is funded by the UK PRP, Prevention Research Partnership. Now, the reasons why this money exists is because of what Antoni's just said. The government is realising how important NCDs are in terms of our health, well-being, ability to avoid suffering, to be part of the workforce, and to keep out of hospital. So the idea of it is to create partnerships between academics and local councils and hopefully health authorities, although that's very much on its way in the rest of the country. And it's the funding is helped by 12 health research bodies which are putting money into this scheme because they feel this is incredibly important. They're all charitable bodies, including the Medical Research Partnership Foundation and other partnerships. So we were a partner in a project which was at Bristol Medical School called Tackling the Root Causes Upstream of Unhealthy Urban Development, TRUDE for short. And if you look at that link, you will see a lot more about the other researchers and the results linked to this research. Just to recap a little bit on what Antoni's already said, in the year 2019, NCDs were estimated to account for 80% of all deaths. Obviously, it shifts a little bit from year to year, but these were the statistics that we were given at the time when we started our project, which was 2019. And you can see here very much replicating what Antoni's already said, that in that year, about half total of those NCDs were to do with cardiovascular disease and cancers. So that's half of the total, but of course the other NCDs are important as well. And you can see at the bottom the statistics for the total deaths and the probability of premature mortality in 2019. So, point I really want to emphasise, Antoni talked about the need for prevention inside the home, and also things like air pollution that can come into the home, differences in temperature and so on. And there has been a lot of research done on this, as Antoni was using the evidence from these previous studies. But there's been a big gap in evidence on what happens outside the home. There has also been a certain amount of attention to what happens inside offices, because, I mean, it may have shifted a little bit since COVID, but a lot of people spend a lot of their time inside an office environment and walking around that environment and commuting to and fro. So we need to think about this external environment and include offices as well as homes. As I said, a reasonable amount's been done on offices now. It's important for commercial reasons to be able to let premises, but the actual environment in between buildings, the pavements that we talk about in this study, and the gardens and the general air quality around it, those have not been looked at well. And, you know, it can impact mental well-being. So one of my PhDs at Reading, Ijeoma Emegi, who's now qualified and left us sadly, she did a study in particular of social housing in Reading, where she discovered how much the environment inside the home and external to the home in the community also impact mental well-being. So the two are very intimately connected, the mental well-being and the NCDs, physical NCDs. And the costs, as I've already said, human suffering, but also actual problems with diminished functioning, which impacts on GDP. Obviously a big issue in the press at the moment in terms of the Labour government and decisions it's going to have to make in the forthcoming budget, and NHS costs, which also is very much in the news, how much the NHS is suffering from the impacts of dealing with NCDs on top of the normal infectious diseases. So all of these have led to the government having this huge interest in healthy design and placemaking, and that was the basis of the funding for our project and for the project itself. So from pension pots to pavements, if design ignores health, short-term returns on investment may grow, but the NHS and the UK economy, those costs rise. So it's a straightforward relationship. But if design can support health, then we have a wholly different situation. Both pensions, the NHS, and the UK economy benefit, and we benefit as individuals. Often in the kind of cost-benefit analysis with this, private lives get left out, you know, but it's what you're here for, presumably, is to learn something about that. It's what I'm here for, why I get out of bed in the morning, why I'm interested in this research, because it affects every single one of us personally. And the amount of human suffering as a result of these chronic diseases is incredible. So we must think of that alongside the economic problems, how the NHS will survive, how it will cope, how the economy as a whole will cope. So if we can redevelop our urban areas in a way that's healthier, it can have long-term benefits for all of us, as well as supporting economic returns. So design for health, why do investors care? Now, this is something that may seem counterintuitive to you. You probably think of property developers as people who are all about greed, all about profit, all about short term. And, you know, I have to say that it was news to me when I did a previous project for the Urban Land Institute that was funded by investors, and they were very involved in the research itself. And I then learned that for sustainability reasons, and because we now live in a shareholder society where all of us in one way or another, whether it's through our pension pot or whatever, we are all involved in being shareholders, even if we don't recognize it in that way. And, you know, in that new shareholder environment, there is huge concern about sustainability. Environmental, social, and governance. How is our money being looked after for us on our behalf? And actually, the long-term investors in the built environment have to care about that. They say to me, it's not because we have a halo. You know, we're not saints. It's a commercial determinant of the way we do things. And over a long period of time, with they hold an asset for 10 years or more, what they need to do is they need to get a return on the commercial investment, a large proportion of which has to go back to us, the wider population, because we are involved as shareholders, whether it's through our pensions or private shareholdings or whatever. So they are responsible for doing that. And in order to stay in business, therefore, they have to care not just about the E and the S, but part of the G is making sure that health and well-being is embedded in the S, the social benefits that they're providing. So what we heard, before we did the case studies, which I'm about to present next, we spent a lot of time doing literature reviews, doing policy document analysis, and doing interviews, in-depth interviews with the people in the business who know how it functions and how minds work these things out. And what we discovered then is that a key missing factor in the data on health that investors, long-term investors, need is around the monetization of the health costs, which they are creating by not designing healthier places. This is something that can be accounted for, and when they do their reporting for due governance and diligence to their shareholders, they can report on actually, monetized costs that they're saving by doing things better. So the case studies that I'm going to talk about today are a case study in Bristol and a case study in Birmingham. There is a third case study with a different investor in Manchester, and we haven't yet published that report, which is why I'm not including it today, but it produces other incredibly interesting results. And the reason why we're focusing on case studies in the cities where we are is partly because Bristol and Manchester were our partners in this UK PRP project. And therefore it was of interest to them and their policies going forward. But also because the case studies were assets on urban brownfield land, which is land that has been used before, it's been developed, sometimes it's highly polluted, etc. And local councils have designated it brownfield as suitable for redevelopment in more sustainable ways. So we used, developed by one of our partners in this project at Bath University, economists developed a health appraisal of urban systems model. And it's the kind of scientific evidence that Antoni referred to earlier, which was used to inform this model. So it's the same kind of criteria about, the environment which has gone into this model. And the results can be found here. So by clicking on these links later, you'll be able to access the full results. And I've only time to just summarize very, very briefly what the results were. Also, you can access a downloadable copy of the model. So if you're from a local council here today or another organisation that would like to see the model, you can do that. You can download it and you can actually use it following the guidance that is attached. So it's not an epidemiological model, but instead it tries to quantify the value of expected changes to health. And these are the features that are included: features of the sites and their boundaries, demographics, baseline health risk in the local population, which often can be very deprived in these brownfield areas. Time and spatial dynamics, changes in cases of disease, premature death and life years lost, value of societal cost of illness. All of these were embedded in the method. These, for the Bristol and Birmingham cases, were the kind of data, local data, that were employed. I won't bother to read all of them out. St Mary Le Port, Bristol. Okay, so why did we choose that one? The pre-existing condition of the sites, poor perceptions of safety within the park associated with it, quality of walking and cycling infrastructure, all of them prevented that area from being a positive asset for health. The site was selected partly also to test what the investor thought the health cost savings would be of that particular site, because it was at a pre-development stage. It was still undergoing planning consultations. So that's why we chose it. And here are just a few pictures of the before. This shows you what a grungy environment it was. And I saw our two interpreters over there doing a demo of what that would feel like. And it was very good. And as a young mum, a new lecturer at Birmingham University years ago, I empathise with that feeling. So a good case to look at. This is an artist's impression of the after, because as I said, it's pre-development. And as you can see, you've got people happily in family groups, walking around, exercising, dogs, etc., not looking at all like they're feeling that feeling. Health cost savings, even though this was pre-development and not everything could be taken into account, the health costs amounted to 13 million or around, which is about 1 million more than the local authority had hoped for. So quite good in terms of performance pre-development. Mostly, and this relates to what Antoni was saying, they relate to access to green spaces, nature, additional biodiversity, security features related to crime and community safety concerns. I took a group of our students, real estate students, there for a study tour. And we had to tell them at the time, don't go there, because it's not a safe place, needles lying around and all that sort of thing. It was definitely security features that did not, they related to crime and community safety concerns. So significant additional health benefits will happen. We know this once it's built. For example, that will be leisure users of the park, which was in my artist's construction there. But we can't obviously calculate those pre-development. So that 13 million is an underestimate. Paradise Birmingham, it's similar. Poor condition of buildings, barriers to permeability, poor perceptions of safety. All of this relates to what Antoni said earlier. This was before the work began in 2016. These were significant risks to health, in addition to underlying risks such as air pollution and noise pollution, which Antoni also mentioned. So this was tested to look at the health cost savings at successive stages of the development. And again, here we are. This is the sort of grunge part, the befores, not nice at all. And this is the real after. And as you can see, it's a bit like an artist's impression, but this is actually real. And this is Federated as MEPC, which is a recent picture. So completely different environment. Health cost savings, as you can tell, predict this is a lot higher. And if the plans for the third phase of this development go ahead, then we reckon it's going to be 43 million, probably, in health benefits for the area. And that's 20 million more than was expected by the planners. So they should be thrilled. Further improvements to increase the green space, reduce noise and air pollution, removal of or downgrade of nearby major roads. That would be an ideal scenario for more health benefits. And I just want to point out there that that is beyond the control of the actual asset holder, the investor, because that would require the local authority to collaborate with making changes which would stop those horizontal and vertical airflows of polluted air, which is to do with the traffic flows in the area. And also noise, that's another one that requires local authority intervention. So takeaways from the investors, this is actually both investors that we've consulted, the one in Manchester as well. Pioneering initiative sets a powerful precedent for how the real estate sector can integrate and prioritize health into investment decision-making. On the acquisition of a transaction, part of our ESG process, we will now look at social impacts. And up until now, we didn't have a particularly good framework to understand what investors are actually committing to. Because obviously, if the investors have to commit to this amount of money being spent on buildings, landscaping, etc. They want to know where it's going, and they want to know it's going to something healthier, more livable, that it's going to save lives and it's going to save suffering. So another one, we now have data-backed evidence to demonstrate that thoughtful, human-centric design drives lasting value creation for the people interacting with the place, wider society, and our investors. And important here is that this is the surrounding community. You know, it's not just about the office workers or the homeowners or renters within that development. It affects the community in a deprived area. So it certainly prompted us some important reflections on how we can begin to tangibly understand and evidence the value we create through our places. It gives us a clear idea of where we can focus, the areas we need to look at going forward. Repairing themes was the biggest and most important risk, and that is the biggest risk to health. So that message has certainly got through. So in summary, you know, the points that Antoni made, especially on his last slide about what were the health opportunities that are available to us, those case studies demonstrate how all of them can actually be achieved. And I attended a meeting, well, I actually presented to a meeting of Share Action in London last week, where it was populated, all the participants were shareholders and investors, to explain to them, you know, how these schemes can actually benefit their aims for ESG, and particularly fill that H gap in the S element of ESG. And it went down very well. I'm doing a survey with their responses to that presentation at this very moment. So a joined up approach can target deprived areas for health by design redevelopment, which can benefit pension holders, the NHS, the UK economy, and all of us. A collaborative joined up approach is necessary, and it needs to involve health and planning authorities and investors to achieve the best outcomes. Now on that, I have done some work for the Office of Health Inequalities and Disparities. Actually, correct that, it's not inequalities, improvement and disparities, OHID, where together with a group of participants, we were working on a design code guide so that local authorities, investors, developers would have some guidelines to what healthy by design looks like on the ground. Now that's eventually being published, not by the government, but by a group of us who were involved in that OHID study. That came out in 2025. And the idea of that is more linking between health authorities, planners, investors and developers to get this right in our local areas. Hopefully that will be rolled out across England anyway. So they need to be built into decision-making early. That's really important. So, you know, when an investor is thinking about buying an asset, which is going to keep for 10, 12 years, whatever, they need to work out where is the mitigation for these costs going to come in. They can design it in the beginning, great. But if health issues start to arise to do with that asset later on, they need to bring in the income streams to deal with that. So it really needs planning early on and consistently. And yeah, the other thing which I'm working on at the moment is how designing for health can be shared and spread between decision makers at local, UK and international levels. And one of the advantages of having an international investor, as Federated Hermes is, involved, is they have already testified that they have spread this through their networks cross-border, especially in the US market, which is huge. In the UK, design for health should inform national planning code guidance that I've already mentioned, and hopefully that will happen going forward. So I'm just looking at the time. I normally overrun, I'm afraid, through enthusiasm, and I've done so today. But we're going to ask for questions in just a moment, but we would ask you before you start shouting questions out to scan the code on the next slide and take part in our own survey. And thank you very much for coming. And we will be especially grateful for your thoughts on the next slide. Well, I hope you've had enough time to have a go at our survey. The reason for us putting this survey there is so that we can get your reactions to the information that we have shared today, to find out, whether this has changed your views on the one hand, and also whether you think there's other things that you and all of us should be doing in order to advance progress, to finally do something about mitigating this terrible rise of NCDs. Okay. Thanks, Antoni. Watching out for my back. Right.
So has anybody got any questions for Kathy and Antoni?
Thinking about the design and the features that are necessary for a good environment, how do you view the current pattern in Reading that whatever is being built is flats? Can you get a really good environment for living with the density of residences that Reading is producing?
Flats. Do you think there's any difference between the high density in flats, living in flats?
All right.
Mhm.
Well, we didn't specifically include that in this study. However, it has been covered elsewhere. And indeed, it has been, so the paper I mentioned, written with my PhD student, Ijeoma Omegi, a lot of that evidence is reported there.
Yeah, it's not an argument between houses versus flats in terms of health perspective. It's about what happens in these places. In flats, which are designed properly, where there are places where people can walk, and also there is a sense of community, then we know that that is actually beneficial for health. So the design in these things are quite important. And also, what is the built-up area where these places are? They're very densely populated, are they more spread out? What's important is that in terms of healthy for design, if we can design these things in advance in the future, then we can also improve the profitability, because there will be increased tendency in these places. People feel that this is a place to invest, it's healthier. Going back to places that have already been fit, then we need to be thinking about how do we retrofit some of these places, not bashing all these beautiful buildings we have, but how we think about how we can do that. And there are things we can still do. So traffic-like environments, neighborhoods where are low in traffic, where there's more ability to walk, cycle within the existing places are still things that we can do.
I can add a little bit to that from Ijeoma Omegi's study, which is that whether you're renting or whether you're an owner-occupier can also make a big difference, because it's about choice. And choice, of course, not only affects what kind of, flat or home it's going to be, but also the postcode. So, the environment immediately around your home or your flats may have an issue with security, for example, or, you know, for people of a particular disposition, age, whatever, or if the families have got young children, you know, they may have particular anxieties about the area. So I would say that, you know, it's as Anthony said about, you know, the general environment of the home rather than whether it's a flat or whether it's a house. But the tenure can be important, and it's, you know, having choice is really important in terms of reflecting our personal needs for us to feel comfortable and secure. Just the other thing is that sometimes tenure, and it can be private sector or it can be public sector, can be related to issues of damp, which Anthony mentioned first in our lecture, you know, to do with how fast repairs happen, whether they happen at all, and so on. So, you know, I would say that tenure is important in terms of choice, and then also making sure that whoever is responsible for that property is able to get the repairs done as and when they need to.
So given that the rental market in Reading is extremely buoyant and rental places are very hard to get hold of, what is the incentive for a property developer to build presumably a lower density? I can see that obviously there are huge potential health benefits, but that's not going to help the developers much at all. So why should they build it at a lower density and at a higher cost and hit their revenue stream by not attracting so many purchases?
Yeah, that's a very good question. I don't think profit and health are separate things. I think they both can go together. If we are developing a new place, I think people are more aware now. Investors are certainly more ethical in their purchases, in their investments. And if a place looks safe, it looks like a place that they can raise children, they're probably going to have more people investing. The tendency is going to be higher. Rental is probably going to be higher as well. And I think that's quite an important message that has to be shared. And secondly, in terms of policy, in terms of urban planning, and it's important that there is some regulation about this as well in building up in very sort of built up areas, because that cost in the future on the hospital next to it is going to be significant. And so there needs to be a bit more long-term strategic planning in this. In the short term, if we go for profit, in the long term, the NHS pays.
Yeah, I mean, there's a real difference between short-term investors and long-term investors. Long-term investors, it benefits them to, you know, invest in health. That's what the results of our study have shown, because that will actually improve the return on the investment over that period of time. And it may increase the return on the investment, not just avoid it reducing, but actually improve it. I mean, the interviews that I've done, the session with Share Action last week, there's a huge amount of evidence that this is really strong now in the investment community. And, you know, it's actually us as, you know, people in the community who are bothered about sustainability and hopefully health, that are able to put pressure to make sure that this continues, and that actually short-term developers, for example, who buy a piece of land, or they probably buy an option on a piece of land, they wait until they get planning permission on that, and then they borrow the money short, they build fast, they sell for owner-occupation, and then the risk passes to the new owner-occupier. That is a sort of profit-based model, and we're not talking about that. We're talking about long-term investment where a lot of the investment will be in rental property. And for all sorts of commercial reasons, therefore, thinking about health can be an advantage for those kind of investors. And, you know, the individual shareholders and investors whose money they're responsible for. And there are legal responsibilities, particularly for REITs, real estate investment trusts, which require them to make sure that they, their diligence is as it should be, and that they do maximise the return to the investor. There's a hand up at the back there.
No, I mean, it's a good piece of work, but with few surprises, I would say. A nice environment generates a healthy environment and a healthy social infrastructure, doesn't it? So, but I mean, putting data behind that obviously is very powerful. But it strikes me that whilst we might have more ethical investment pressure these days, the key thing here is whether councils actually have the legal right to put what you're saying into practice. So, for instance, if you just take the flats in Chatham Street, family flats, signs up saying no ball games, no skating. Bit of clear stupidity there, and the council should have the legal right to say, no, if you're building family flats, you've got to let the kids play. But similarly, if you look at this, you stress the importance of kind of a holistic, joined-up approach. I mean, a council should be able to say, well, this will actually keep people out of the RBH if it's done in the right way. But the council doesn't have that power today. So really, it seems to me that the power in what we've developed is somehow in creating legislation that says the council must and can look at the whole area, the healthcare burden, the social burden, as well as the crazy
Are you, sorry, but are you,
take a decision and actually give them the power to say, no, we're not having yet more UPF takeaways, we're not having places built without green spaces where kids are not allowed to play, and actually use that as key planning criteria when they're asked to approve anything from
it sounds as though you're talking in general, not about brownfield sites in particular, is that right?
Well, it's both. I mean, brownfield sites clearly would tend to be, I would guess, the majority of sites that take place in urban centres, because there's probably not many green spaces that can be left over. But yes, both in general, but also in brownfield sites in particular.
Are you speaking, as a representative of a council, or I was just wondering,
well,
because
as a local taxpayer, I guess I'm some sort of representative of the council, yes, but not more than any formal representation. No, it's just I'm just someone who lives in the area and hates to see the inefficiencies of the planning system creating health problems and urban developments which seems to be focused more on squares of glass than actually livable spaces.
I'm finding this a little bit difficult to interpret because I mean, I'm MLTPI, a member of the Royal Town Planning Institute, but have been a practicing planner in the past. But planning controls are fairly strict. There are lots of tools that planners can use to oppose development that they are aware, are not socially responsible. Any comments, Antoni?
No, I completely agree with you. It's a nice thought. You have a nice park, a nice place to walk. The thing is, we're not doing it. And we're seeing more and more NCDs. So we can all say, yeah, that's a nice thought. Let's carry on. We'll get to 9 out of 10 deaths from NCD, and soon it'll be 10 out of 10. And then we'll say, oh, maybe we should do something. We still have an opportunity today. We're talking about the next generation of people, from the young people here tonight. This is about what's going to happen in the future. So yes, if it's that, that's what it takes, then we certainly need to articulate that. We need to be, promoting that.
I think councils also need to themselves be better informed about what actions are needed on their behalf, because from the interviews that I've done for this 6-year study, one thing that I did learn is that there can be a bit of a silo effect between the health authorities, the local authorities' health experts and the actual spatial planning department, the communication isn't always as it should be. And for example, a number of investors said that it would be more helpful for them when they're doing their planning if there was more of a unified voice coming from the public sector side, whereby they could be told, and this was partly the reason for being involved in the design code guide, this is what healthy looks like on the ground. So, you know, I think there needs to be more joining up across silos to make sure that the information, as we hope we've done today, links together the clinical evidence with, you know, the practicalities of how you would actually do this to create healthier places. I think that is certainly necessary, and it's something that we'd like to work on further.
It seems clear to me that the environment has a profound effect on our health, both mental and physical. So I wanted to ask you about some of the numbers that you had on the slides. 43 million saving for the health system seems to be very impressive, but I was wondering under what period, what does that actually mean?
43 million saved.
Sorry?
43 million saved in your slide. 43 million pounds saved. 43 million pounds saved.
So you're surprised by that?
No, I'm not at all surprised. I think I'm impressed. But over what period of time? What does that actually mean? 43 million pounds saved.
What it means is it's saved for the country, for, you know, the health authorities, for the economy. It's money that hasn't been spent on mitigating the results of NCDs because they're not happening. So I understand it's a bit strange to do it that way, but health cost savings is simply the way the model works. It's to show if this intervention, physical intervention, had not happened, we would have had these NCDs arising, and it would have cost this much to the National Health Service and the economy. So that's the way it's done. It's not money that's earned; it's money that hasn't been spent.
I think you're kind of saying that's the net present value of the savings.
Yeah.
Where's that coming from?
Thank you. First of all, may I thank you both for the fascinating content of your talks. I've been involved in the planning in Reading for the last 35 years. It's interesting looking around this hall, I can't see any members of the current Planning Applications Committee on Reading Borough Council here. I'm sorry I've missed you. I think that's a great shame because it would have been a great benefit. Now, I was actually at a talk last night at Green Park, south of Reading, the large commercial estate, and they were told that's 25 years old. And they were saying how they had a huge amount of work to do there because when it was built, energy conservation was not regarded as important. And those buildings are energy E, and they are now trying to do work to get them to A or B. It's interesting to see that new applications in Reading of a similar style are actually coming in at usually an A energy rating. Now, with regard to your talk this evening, what would you like to see in, let us say, the next 2 decades, put into planning regulations, and I say regulations, not just aspirations, so that the actual what would have been built in 20 years' time is very much reflecting what you want out of it. So as I say, not aspirations, but requirements.
I mean, this is a constant debate. And of course, it could be something quite crucial at the moment because the government is really trying to increase house building. It's also an issue when it comes to change of use because, as you know, the government is very much encouraging spaces like office spaces, retail spaces that are no longer required for that use to be converted to housing. So I think the standards, this is something that needs to be watched carefully. And certainly the regulations need to be constantly revised and upgraded to fit the situation. At the moment, the government's very, very fixated on house building. And so, you know, in a way, when you say in 20 years' time, that's very relevant because, you know, we mustn't race to get things built if we're going to, you know, if we're not going to impose the regulations as we should do. And I think to some extent, it's a bit of a learning curve. We've already learned, for example, that converting buildings from another use to housing cannot be satisfactory in terms of, you know, things like numbers of windows and location and all sorts of other reasons. So I think it's just something that we need to keep on top of. And, you know, one of the things I've suggested in the survey is, should we, as members of the general public, you know, expect more from the public sector in terms of information about what they are doing to build health into our local environments. I mean, I think it's just something we have to keep monitoring. And I totally agree with you. It's something we must do. Otherwise, we're not going to achieve what we set out to achieve. The design code guide could be very useful with this in terms of indicating what would be poor design, what we must avoid. And it also means then that when local plans get approved, it has to go through this process of does what's being proposed here comply with healthy design? So I think that could be something that could be spread across certainly England for a start, so that all local areas, local authorities, councils, planning councils, and investors and developers are aware of what healthy by design looks like. But you know, it's a question of having the standards, understanding the baseline evidence, clinical evidence as to what matters, and then making sure that that is translated for people who are not clinicians so that they can understand what that would look like in practice. And you know, it's being requested all the time.
Thank you very much. I'll send you a list of things that I think should be very important on a postcard. I think data, the research that Kathy is to describe, these are things that are there. They're starting to build an evidence base for the future. And I think urbanization itself is not the problem. Urbanization planned properly is really good because we're actually improving people's economy, strengthening their economic wealth. They can get jobs in these places. But what happens is, if we don't plan that properly, we have baked into that a future healthcare problem. And my list would be simple. They're all P's: parks, pavements, places to walk. All of these things built within that environment in the urban areas are certainly things that we need to be considering for the future.
Can I just also add to that? That's an important point Antoni has made. And something that we haven't specifically asked you is about deprivation and inequality. Now, you may be surprised that Reading has this. Certainly, you know, Reading seems to be a thriving, prosperous place with a very good, quite international economy. It's actually, according to various government statistics, second only in this country to the City of London in terms of its internationalization, its contribution to the economy of the UK, which is surprising. It's small. It's only a town. It's not even a city. And yet it has this, it's near Heathrow, it's near central London, it's very accessible, especially now with the Elizabeth line. It's on this fantastic, motorway corridor. And this enables it to have this role in our economy. But there is this pocket of deprivation in Reading, which often isn't acknowledged. Now, if that can happen in a city like London or in a town like Reading, and you think about the rest of the UK, what are we going to do? That is one of the key things Antoni mentioned that's associated with health. And that's why we focused on brownfield land for our studies. So, who is thinking about this? How to reduce inequality? To what extent can the government do something about it? To what extent, things like budgets can do something about it? Because that is really key. In the end of the day, if we want to have equality in terms of health, equality in terms of our local environments, we need to have some kind of equality in terms of, our earnings and what we can afford in terms of where we live.
Kathy and Anthony, hi, over here. We received several questions in advance of the lecture from people online. So I just wanted to ask you one of those, if that's all right. Kathy, you just mentioned there about kind of what can people do about it, and there's a good question here about what kind of people locally can do to advocate for healthier neighbourhoods where they live. So do you have any suggestions for actions that people can take?
I think we can start. We can start tomorrow. We can walk around the neighborhood and we can survey and we can see what's available around where we live. Are there places for us to walk? Are there places for us to go to? Are there parks, pavements, pathways? Is it car-free? Can we cycle in these places? What is around us? And secondly, I think one of the things is community. One of the things that we haven't talked about is the whole idea of, in the context of deprivation, is isolation, where people don't have any more sense of community in the places where they live. And if you look at the data, the risk of isolation is as high as the risk of smoking in terms of mortality, in terms of increasing it. And I think as we get into this whole discussion, that's not to be forgotten, is the ability for people to meet. So is there a bench? Is there a place for people to meet? Is there a community place? Are there one of these things in where we live where we can encourage some of these aspects of healthy living? So my first thing would be to survey what we have, and secondly, to talk to our representatives, people who are probably in position to influence some of these decisions, to start making these changes before we start talking about bigger changes.
As an ecologist, a lot of brownfield sites I visit have a surprisingly good amount of flora and fauna. Do developers use biodiversity net gain as a good opportunity to integrate green space for people with the net gain, or is BNG generally viewed as a separate issue for green space for people?
I'm having trouble hearing from the back.
So as an ecologist, a lot of brownfield sites I visit have surprisingly good composition of flora and fauna. Do developers view biodiversity net gain as a good opportunity to integrate green space for humans with the net gain, or is BNG generally viewed as a separate issue to green space for our well-being?
Yeah, brown sites. She's talking about brown sites, the future development of brown sites.
Yeah.
What do you think? How that kind of relates to what we are talking about?
Yeah, I mean, obviously we did focus on brownfield sites because of what we were just mentioning before about deprivation. But something I forgot to mention in the lecture is that Reading has a lot of brownfield sites, as does West Berkshire. And, this is for another conversation, obviously. But, Antoni had the statistics about deprivation with his map. And it would be very interesting to know, to what extent that map coincides with the brownfield sites that have been designated. I think, the issue about for us using brownfield sites is simply because we were doing this. It was a UK study. We've obviously focused on the cities that were part of the study in terms of our partnerships. But the study as a whole wants transferable data that can be generalized for other cities as well. And that was why we targeted those specifically, because they're areas of multiple deprivation. They're obsolescent economically, in terms of often pollution, and in terms of their population being, not part of the regular population who are earning and have equal opportunities to choose their postcode, etc. So this was the reason for it. And that's why the health cost savings that we managed to survey are really important for those particular areas. And as I said before, at the different stages of development, you will see that benefit to a wider community outside the areas which have been the asset that we've focused on. Now, I'm not sure if I fully answered your question, probably not, but I am having a lot of trouble hearing right from the back.
The second part of the question was about biodiversity net gain.
How might?
Biodiversity net gain, and whether that is considered in addition to green space. So would planners be looking at biodiversity net gain specifically over and above green space?
Whether it's, sorry, what was the link to?
Biodiversity net gain.
Biodiversity. Net gain.
Which city?
Biodiversity net
Oh, biodiversity,
gain.
okay.
Net gain. Would that be something that?
Yeah, I'm sorry.
Yeah.
The biodiversity was one of the ones I mentioned. It's biodiversity was one of the issues that came up in what we looked at. They lacked biodiversity before the development, and they were dealing with that in the asset design. So something I can enlarge on here is that the other site, which I haven't yet been able to talk about, which is at Manchester, that is actually that's a park, it's Manchester Park. The whole site is green as it's being developed. They even diverted a river in order to create it. As I said, I didn't want to publicly announce the health cost savings there, but they are vast. That's because the entire site is green. Now, if you were to make any of these sites that we've looked at 100% green with the biodiversity, then obviously, that's going to produce excellent results in terms of health cost savings. But it's more important to look at mixed development, and that's why we've done it with 2 of our sites, because that is actually affecting the population who will suffer actually locally within a community. So although a totally green site with lots of biodiversity, let's say you just put woodland across the whole site, that will benefit, the whole city to some extent. But what we're trying to look at, what we're trying to focus on, is deprived communities within a specific area of a city, such as the areas that Antoni showed on his slide, and to see to what extent then NCD costs will be mitigated for the deprived population in that area. If we were looking at a whole city scale, we'll be looking at the whole population, but for our study, we deliberately focused on specific sites in specific areas. And yes, biodiversity was one of the measurements that was used in this.
We are sadly out of time, but Kathy, Tony, you've given us some fascinating insights on the fact that where and how you live can literally speed up your biological clock, that we all carry a certain level of inherent risk, but the air quality, temperature noise and stress, green space and safety are really key factors, and that housing should be a frontline health intervention, but officers are important too, as is our broader environment. And Tony, you told us that there were mechanisms for this, that these factors affect your epigenetics, your cortisol levels, and your immune system. And I was really intrigued to understand that noise and stress can affect your health and biological clock through your cortisol levels. And it left me wondering, is it worse to live under a flight path or to have a partner who snores really loudly? But that's slightly outside the main topic. And Kathy, you explained that collaborative, joined up approach to designing for health is really required, and that help by design solutions need to be built in to decision making early. It seems obvious, but it's about thinking about the people living in the buildings, not just the structures themselves. And audience, your questions have really highlighted some of the challenges around that. So Kathy and Tony, thank you so much for your insightful lecture tonight. Please show your hands. I hope you enjoyed this evening. Thank you so much for coming. Please do look out for future lectures. Really hope to welcome you again. Thank you. Enjoy the rest of your evening.